Gustav Leinhardt Award of the Institute of Medicine. Amongst all of these honors and awards and his outstanding accomplishments, it was telling to me when I was visiting with him that one of the things he is most proud of is that he's the father of 2 physicians. And I think that is a remarkable introduction. And Dr. Schroeder, thank you for taking your time on the weekend to come to Oklahoma and be with us and to deliver the keynote address today. Please welcome Dr. Stephen Schroeder.
Can you hear me? So it's a pleasure to be here. I want to comment on 3 things that really stand out. One is the energy underlying this effort. All the people on this slide, people here on a Saturday morning, it's incredible. Second, you got a happy dean. It isn't easy, as Kermit the Frog said, being dean these days. And you have a happy dean and one who's really in back of this. And third, how Oklahoma is sort of an untold story about how much you've done to improve the health of the people in your country, in your state. Now, I'm going to show you're not all the way there yet, but you can certainly make progress. So it's a real pleasure being here. And I'm going to cover today the health of the state, focusing on smoking. Why focusing on smoking? Because it's what I do. I work on smoking, but also it's still the #1 killer. And then move to access. I love this bridging between health and healthcare that you have on the effort today. And you have to do both. And you shouldn't be forced into a dichotomy that is either or. And then finally, Gary asked me to talk about next steps. So let's talk about our country first. We don't do very well in health outcomes as a nation. And the OECD is a listing of about 32 wealthy countries, and we rank not very well there, not very well in the whole world, in spite of the fact that we're #1 in the nation in spending, in the world in spending for healthcare. And there was a recent report of the National Research Council and the Institute of Medicine that tried to analyze how does it happen? How do we do so badly as a nation in health in spite of spending only almost 1/5 of our GDP on healthcare? And they came up with, and here's some data just to show what's happened over the years. This is from the Shoutout lecture that Dr. Feinberg of the Institute of Medicine gave. You can see that the US is in red, and in 1960, we were clustered pretty tightly with these other Western countries. Over time, everybody's health has gotten better, but we're now in red, a big laggard in 2009. And then this just shows by race. Again, in the United States, we've done better over time, but we still do much worse than we should, and there's still huge gaps. And over this time period, white women have gained 7.4 years, starting way out in front. They're still out in front, but not quite as much. White men, 9 years. Black women, 12 years. They've really gained a fair bit, and black men, 10.8 years. And when I show slides like this to our medical students at UCSF, a great proportion of whom are Asian. Last year I mentioned that the group with the greatest health status were Asian American women, and about a quarter of the class started to clap at that, which was So this was what the IOM said to the answer to the question of why are we so unhealthy in a relative way. One is the thing that you're going to hear more about from today, and you've heard more about previous conferences. We consign a large proportion of our population to not having any health insurance, and therefore they either don't get the health care they need or it's pretty delayed. That's one thing. We have greater extremes between wealth and poverty, and you all read about that every day. And so people at the lower end of the scale suffer poor health for reasons other than not getting health care. We eat more, we do more drug abuse, we have more traffic accidents with alcohol, a lot more deaths from firearms and violence. Curiously and nicely, we have lower rates of smoking than most of the other wealthy countries, and that's really great. Our populace on balance is less well educated, and our social safety net, time off for mothers when they have kids, child care, care for people who have a disability, all of those we lag all the other wealthy countries. And finally, in big places like Oklahoma and elsewhere, we're focused on the automobile. So we don't walk as much as some of the more tightly, sort of physically concentrated countries like Holland and Denmark. But there's some good news. If you make it to 75 in the United States, and why do you know, the people who make it that way are hardier. Either we've weeded out all the susceptibles, or this is a group obviously that gets most of the medical care that they would like. But we do better in terms of, so you get to 75 in the US, you're more likely to get to 85 than in most countries. I mentioned that our life expectancy is an all-time high, but almost all those recent gains that you saw were in the upper socioeconomic groups. Interesting. And one of the reasons for that is smoking. So my wife and I live in a gated community. We don't know anyone socially who smokes. No one. We used to know one woman who was sort of a closet smoker. She moved to Georgia. I don't think just because of her smoking. And during the last 10 years or so, life expectancy for the poor, and especially poor white women, actually fell some. So I'm sure you've seen this slide. It's in my Shoutout lecture, which the dean says that some of you have used. And this just shows the causes for premature death. And you'll note that personal behavior, smoking, sexual activities, prudent or not, alcohol, drunk driving, overweight, physical stuff, all that accounts for about 40% of premature deaths. The genes that you're born with, which we can't yet do something about, but we might in the lifetime of the students in the room, 30%. Social conditions, independent for these habits. So in general, the higher you up on the economic ladder, the better chance you have of living longer and living healthier. And the reason for that probably is you have more control over your life circumstances and therefore less stress and all the problems that stress causes. The places where you live, whether there's lead paint, whether there's lead in the air, whether you can't walk, whether there's crime, all those are important. And then finally, healthcare. It's not to say healthcare isn't critical, and if you want it, you should have it. But if you gave everybody in Oklahoma the best healthcare that they could get when they needed it, you'd still only save about 10% of premature deaths. So in this category, let's break that out, and you'll see that smoking, this number is up to 480,000 now, but in 2000 it was 435. It accounts for about 435,000 of those deaths. And about 200,000 of those occur in people with mental illness or substance use disorders. So a huge chunk of that. Big headline in all the papers when the first MOCDAD study came out in 2004. Obesity and physical activity are about to overtake smoking. Turns out they made some errors in their estimations of life expectancy from people who were overweight and somewhat older, and estimated those people would die earlier than they were going to. There was pushback on that. So they remodeled and they said, well, no, it's not 365,000, it's 112,000. It's still a lot, but it's a lot less. So I'm not going to live long enough to see this overtake that. You may not either, I don't know. And then you can see the other things here. And yet you wouldn't know it from the headlines because deaths from smoking are so much a part of our life that we kind of take them for granted. Homicide rates. This is probably the most shocking slide you're going to see today, showing homicide rates by homicide rate per 100,000 people by race. And you can see here that, and this should be for males, that black males in young group, there's a huge toll taken. And it's something that we've sort of thrown up our hands as a nation and said, that's the way it is. And we don't understand why it happens very well. We haven't done anything to try to stop it. And I think it's a disgrace. How are you doing? Better, but not great. You're 44th overall in health ranking. You've made progress here. You're 39th in smoking. Your prevalence fell from 26% to 23% just in the past year. And my congratulations to your settlement and endowment trust leadership, your tobacco settlement endowment trust. your leadership academy for wellness and smoking cessation, and other people are working on that. But you still have over 500,000 Oklahomans who are still smoking. So if there's one thing you could do to improve health, it would be that. In obesity, you're 45th, almost a third of all adults. Physical inactivity, about the same. 43rd in diabetes, only 9th in binge drinking. I'm not sure why that's true. And 46th in substance use. So that's your scorecard, briefly. Second part of it is that, probably for reason of politics, public health funding has decreased by 40%. I'm wondering whether the politicians felt you couldn't do any better and you're going to settle for 44th in the country. I would hope not. I hope there'll be some kind of pushback on that, but that was sad. Percentage of children in poverty rose from 21% to 27%. You're 41st in violent crime, 39th in lacking health insurance coverage, 48th in immunization, 33rd in low birth weight, 47th in teen birth weight. So these are opportunities for those interested in public health, and you can do better, and as you are in smoking. So let's turn to smoking now. I'm going to start with 3 graphics. This is the cover from the famous Surgeon General's report on smoking and health. We celebrated its anniversary, its 50th anniversary in January. An amazing thing. It was fraught with politics. President Kennedy really didn't want to start it going. It came out after he'd been killed, but he got it going. And JAMA put a special issue out on the January 8th for its January 8th issue. And it had this amazing cover. And this is Luther Terry, who was the Surgeon General. And there's a lot of things. So if you have that chance, you should take a look at this, because it's a pretty amazing set of stories that feature that. It's got an editorial by me also. And you all read about CVS, and this is a cartoon in our local paper, which I thought was kind of nice. There's the Marlboro man muttering off into the future. By the way, all 3 Marlboro models have died of lung cancer. So, you saw about smoking, and it's the recent report of the Surgeon General, time to commemorate the 50th, showed that the number of dying now is up to 480,000. Now, smoking prevalence is coming down, but there's a lag period, particularly in lung cancer, between when the rates go down and health effects get better. And so we're still on the going up on that, and also our population's getting bigger. So it's 480,000 deaths now each year. Almost 5 million annual deaths, 10 million deaths estimated by 2030 in mainly overseas. 50,000 of those 480,000 are from exposure to secondhand smoke by non-smokers. And we've got about 16 million people in the United States who are living, often very uncomfortably and painfully, with illnesses caused by smoking. About 45 million smokers in the United States today, 78% daily smokers, and they're averaging about 13 cigarettes per day. Now, I love this slide because I keep adding to it, and the yellow is what I've added in the last couple of years, as data come out to show that the odds ratio of getting these diseases is increased by smoking. Nowhere is it as high as lung cancer, but all the others, the odds ratios go from 1/4 to 5 to 6 to 7. And so it's not just lung cancer, it's not just emphysema, it's not just heart disease, it's not just strokes. It just causes a lot of health problems. And for your friends and relatives and older colleagues, it's never too late to quit. And if you had a slide, they didn't have it in this paper, but I'm seeing from the Brits, even at 65 to 74, you'll save a couple of years. So it's never too late. Mental illness. 200,000 annual deaths from smoking occur among, as I showed on a previous slide, people with chronic mental illness or substance use problems. Why? Well, this population consumes about 40% of all the cigarettes sold in our country. Why? Because people with these illnesses smoke at a much higher rate. They smoke more cigarettes per day than the average smoker. If you go outside an AA meeting, you'll see Marlboro butts, and you won't see any tobacco. People with chronic mental illness die about 20 years earlier or so than others, and they don't die of homicide or suicide. They die mainly from diabetes and emphysema and things like that. And social isolation from smoking is a big part of that. Now, I want to do a shout out to Terry Klein, because when he was the commissioner of SAMHSA, he was persuaded that SAMHSA, which is the Substance Abuse and Mental Health Services Administration, its clients die from smoking. And yet until Terry was the head of SAMHSA in Washington, it never took on smoking. To his credit, it did that. It's some political cost. And SAMHSA now, thanks to Terry, is working on this issue. So I think we should thank him. And I know he's trying, now he's back here, to make a similar difference here. So the trends in smoking, a lot of people come to me and say, isn't it horrible, it's plateaued? It actually hasn't plateaued. Numbers are going down. There was an ad campaign here, which was featured on that JAMA cover, for Virginia Slims, and it said, "You've come a long way, baby." It was clever because it told women that they could lose weight if they smoked. And they did smoke, and now the rule is that women who smoke like men die like men who smoke. But they came a long way, so that gap got narrowed, and it's now persisted in a small way. And these are the most recent numbers. Now, it used to be thought that the people who stopped smoking were those who were, it's a low-lying fruit. It's people who only smoked a few cigarettes daily. Turns out that's not true. As the smoking prevalence went down in the blue line, the average number of cigarettes smoked per day was about a pack a day until 1995. And then it gradually came down, even as the prevalence came down. So now today, the average smoker smokes only about 13 cigarettes per day, and some of them only smoke weekends. And so this is double good news. There are fewer smokers, and smokers are smoking less. Smoking today is linked to class. In my parents' era, nobody in this room is as old as my parents would be if they were still living, but smoking wasn't particularly linked to class. And you think of Humphrey Bogart, you think of glamorous women models in a mink coat smoking, but now it's become stigmatized to people in the lower class, and one marker for class is education. So only about 5% of those with a graduate degree smoke, only 1% of doctors smoke. So very, very low rates. 9% of college students, 22% of some students, 24% of high school graduates, 25% of those with no high school diploma. Anyone want to know, anyone want to guess why it's so high in those who get a GED? Prison. Why are people in prison? Often from drug or alcohol use, and therefore they're high smokers. So this is the highest group, and again, low social class. In that article, in that issue of JAMA, there were two articles that made the following points. One is, in the period since the report of the Surgeon General was put out, the almost 50 years, this is 48 years, there were 17.7 million smoking deaths, there should be million there, that took place. 8 million deaths would have taken place, but didn't. Preventing smoking-linked deaths accounted for 30% of the life expectancy gains. We're seeing those life expectancy gains. So smoking, by far the best thing. And people with mental illness, in the second study by Cook, did not benefit as much from these declines in smoking rates. So how do you lower smoking rates? Well, raising the price of a pack of cigarettes is one big reason. And your price is $1.03. You haven't, I think your most recent raise was 2005, is that right? Something like that. And compared to your neighbors, you're not as high as Texas, and I know Texas is a go-to sort of competition for the states, so you can catch up with him there. But the deep south states, you're kind of better than that. But you've got a way to go, you're under the national average. Why has our progress slowed in smoking? Well, one is, a lot of people think the problem's over. And partly they think it's over because they don't, the influentials, the policymakers, the journalists, don't know people who smoke. So they think it's over. There are fewer places to work on in some issues, and those are harder. It's interesting, the contrast with breast cancer. Pink ribbons, race for the cure, they're heroines. Women are more likely to die of lung cancer than of breast cancer, although there are fewer cases. And yet there's no celebration of lung cancer patients or their deaths because they're stigmatized, and the unspoken message is they made a stupid choice to start smoking. So a real difference there. State budgets, because the spokespeople for tobacco tend not to be as vocal as, say, for breast cancer. Politicians feel more comfortable cutting public health in general, but especially cutting those funds related to smoking. It should have led to more taxes, but didn't in some states. Anti-government, anti-spending, you see it a lot in this state. The industry, which is very, very clever. And finally, fewer advocacy resources. But I think we're getting closer to a tobacco tipping point. So in our state of California, almost just under 12% smoking prevalence. Utah's the lowest, it's 9%, but if you correct for Mormons, Mormons don't smoke, Utah's half Mormon. So if you adjusted for that, they'd be at 18%. So I like to say that California is number one, but national prevalence, as I mentioned, is low. Smokers who do smoke are smoking fewer cigarettes. I mentioned the 1%. And you know about CVS Caremark making the wonderful breakthrough news, which I showed on that cartoon, to not sell cigarettes, and I'm hoping that Walgreens and Rite Aid will follow. People that have said to me that they've changed their patterns, they're going to shop at CVS in a differential way. And even smokers are saying it's the right thing. And an interesting, the latest issue, which a friend of mine at UC San Diego is pushing, is the pollution from cigarette butts, which exert a huge toll on cleaning up, and they're not sightly. So that's another issue. In San Francisco, which is always out in front of these things, is thinking of putting a cigarette butt cleanup tax on the sale of cigarettes. Second slide on why we might be at a tipping point. The Affordable Care Act now gives insurance companies the right to charge smokers a higher premium, creating an incentive for them to quit now. The federal tax went up in 2009. Lung cancer, as I mentioned, there's this lag time. Deaths from lung cancer in men have been going down. In women, they're just starting to go down. And so that reflects that sort of 30-year lag. The stigma of smoking stigmatization is worse. Mass media campaigns, you're going to see in the next year 3 different mass media campaigns from the FDA, from the Legacy Foundation, and from the CDC. And because Judge Kessler in Washington ruled as such, the tobacco companies who were accused of racketeering because of their unsavory business practices are going to have to publish corrective statements. It'll be interesting to see how they weasel that, but they will have to do that. So a lot on tobacco. I'm not going to spend much on the other issues, but I know that a lot of you are worried about those, as you should be. For obesity and physical inactivity, as I mentioned, that's a major epidemic here in the United States, especially here in Oklahoma. Like smoking, it's concentrated among the poor for a variety of reasons. The evidence about interventions is still kind of emerging. It's emerging. It's going to require multiple steps, dietary steps, getting Coca-Cola out of the public schools, making it easier to do physical activity, especially for those who are poor. And we may have stabilized the obesity rate in children. We're not sure yet, but we got a long way to go here. There are a lot of opportunities. Alcohol and drug abuse is a big issue, poverty. So drunk driving laws and enforcement of them have been a major breakthrough here. We could do even better. The Designated Driver campaign has been a wonderful public health story. Needle exchanges to prevent transmission of HIV, and making it easier for substance use patients to get into treatment. There's a real mismatch between the need and the opportunity. So what other interventions could we do to improve the nation's health? Well, as the European countries do, we can have a better social safety net. We're a long way from doing that because a lot of politicians think the poor are undeserving and could pull themselves up if they only tried harder and aren't worthy of getting any federal help or state help. But some of the things would be helpful, and I think your state has been a leader in giving pre-K education. And there's also child care, which is good. What could you do as a state? You could set health objectives. We want to be at this level by this year, and then look at strategies and track those strategies and make that a campaign. And there are people in this room who could help make that happen. You could do media and outreach campaigns to help fulfill those goals. And you could take a look in research and in data as to why you're not doing as well as you might. So, in summary, I want to point out on the health side, we are doing better, but we're trailing all the countries that we think of as peers. We may not get enough credit, and I'm not seeing many other people talk about this, for functional status. So the international comparisons don't look at functional status. And my wife is in a hiking group, and about half of the ladies that she hikes with are not hiking on the knees or hips they were born with. And we get our ears fixed and our eyes fixed. So our old people may do better in function, and that probably chews up a fair bit of money. So we may do better in function, but we don't measure that as a public health community. There are major decreases in heart disease, but not in cancer. There are multiple reasons for that, but smoking is a big part of it. Major opportunities still for improvement in these two areas. You've got to focus on the poor, and the social causes are really critical. And we're in the paradox now where as health gets better, the disparities widen. And when you think about it, who were the first to stop smoking? The upper social classes. Who were the first to go and work out in gyms? The upper social classes. Who were the first to take statins to lower lipids? Who were the first to modify their diet? Where are the vegans concentrated? So there's all this. So we may be in the paradox that the poor will get better less quickly, the wealthy will get better faster, the gap will widen. What you'd really like to have happen, of course, is to narrow the gap this way, with the poor doing better. You don't want to narrow the gap by the wealthy getting worse, and I don't think that's going to happen. So let's now turn to access for healthcare. This is bridges to access, after all. So to paraphrase Dickens, got the best of systems and the worst of systems. And the healthcare I get is terrific. And I'm happy with it, and I wouldn't trade it for anything else. But a lot of people can't get that. Insurance coverage is a major reason why. We're unique. We think of ourselves as a generous country, but we consign about 15 million people, this is in 2009, to not have any health insurance. And they get a little care, but they get it late or they don't get it. And that's about 1/6 of our whole population. And where's that again? It's in the poor, generally. There's been a gradual decline in employer coverage, primarily linked to price, and a shift of expenses to out-of-pocket. Again, $5,000 as a deductible for hospitalization won't mean a lot to me, but it'll mean a lot to someone making $30,000 annually. Geography, language, literacy, racial barriers are also critical, but access is probably the most dominant one. And this cleaves in a political way. It didn't used to so much. Medicare passed with support from both parties, but it's cleaved now, so this has become a partisan issue. I'm going to talk a little bit about that. It veers into politics. I'm not trying to be partisan. Part of this came from trying to explain to medical students in UCSF who live in a bubble. California is a very blue state. The San Francisco Bay Area is the most blue region of that state. In UCSF, there may be a Republican in the orthopedics department, but there aren't many faculty. There aren't many faculty who are voting red. And we have a very vigorous San Francisco General County Hospital where there's a tremendous amount of research going on into social justice issues. So those students from California who've never been to the South, they don't know, why we just don't go to a single payer. I wrote an editorial in 1996 asking why do we tolerate such high rates of uninsurance, which are much less than. And I listed all these, and a lot of these are myths. The first 5 are really myths. The 6th and the 7th are real. There are people who really feel that we can't trust our government. Gary, when I was in Canada just after the Clinton health plan failed, I had to explain it, that the United States people don't trust their government. The Canadians really do. They see their government and they're scratching their head. I said, no, it's really true. And a lot of people, this goes way back to the 18th century. People came to this country to flee repressive governments overseas. And so we have this residue of distrust in government that is deeply baked in our national fabric. And then we set up a system of government to make it harder to change things by design. What I should have mentioned in that article, and I kick myself for not, is number 8. Our political system now is fueled on money, PACs, and also it's fueled on who votes. And the poor don't donate, and they don't vote. Now, the ACA, as you know, it passed. Not a single Republican vote in its favor, as opposed to, say, when the Medicare Medicaid passed in 1965. It's a very, very complicated bill, a very, very complicated bill. And I'm not going to try to do an explanation of it. And many of the details are still in process. But it was actively challenged the minute it was passed. Is the individual mandate legal? What about businesses having to cover people? So what did happen? I'm sure you know most of this, but up to 29 new people potentially covered, 50% under private insurance subsidized through the exchanges either run by the government or by the state, 50% under more lenient rules to get into state Medicaid. Would have raised the national coverage from 83 to 93%. Individual mandates for people who choose not to get covered, particularly for the young people who don't think they're going to need it, and then fines for an employer. Walmart used to enroll its lower paid workers and then give them a Medicaid application form. And Walmart now can't do that under the ACA. Subsidies for low-income families who are too wealthy to qualify for the Medicaid, the penalties, subsidies for the states, generous, enormous subsidies for the states who accept the expansion under Medicaid, and the exchanges giving the ability to get larger populations, so to split of risk. So this became a political lightning rod. The two parties really differed in their settings of access. When the Clintons tried to pass health insurance in 1993, a number of the leaders of the Senate, including Senator Dole, were going to do something. And a very influential political consultant named William Crystal wrote a memo to his party saying, don't do anything to expand health care. The Democrats will get the credit. It will cost us votes. Whenever they compromise, ask them for more compromise, but never sign. And that worked. And so ultimately the Clinton plan failed. Now it's interesting, when Medicare and Medicaid or state children's health insurance plan or Medicare Part D passed, this is under Johnson, this is under Clinton in '99, this is under George W. Bush. They were succeeded by a president from the opposite party. There was no attempt to defund those programs. In 2008 and 2012, the candidates for president, or in 2012 I should say, the presidential candidates on the Republican side, each one said the first thing that they would do would be to defund and veto the ACA. So cleaved along parties in a way that it hadn't been previously. And so this was a slide I put together for the students at UC San Francisco who were curious. And this is a Schroeder kind of an antenna. Others might not see it this way, but this is why I think the Republican Party is not as interested in expanding health care. One is, when you poll the voters in the primaries, it's like number 20 or number 14, whereas under Democrats it's number 1, 2, or 3. So very different salience. So I mentioned it's seen as a Democratic Party issue. Philosophical opposition to an expansion of government, which is deeply felt. Belief that charity from the private sector or provide needed access. Paradox, of course, that the reddest states have the highest rate of the uninsured. And a lot of those are people of color. And you can do the math with that one. And a personal, I think, antipathy to our president among many of the red states and the politicians from the red states. So that's my sense. Be interested afterwards if any of you have other theories. And this was a study of voters taken as exit polls in 2012 after the presidential campaign. So the O voters for Obama and the R voters for Romney. How much does government do too much? You can see a huge difference by party. Should government solve more problems? Huge difference by parties. What should we do with the ACA? Expand it or leave it as it is? Almost 80% of the Democrats, 10% of the Romney voters, and of course 80% of the Romney voters said let's repeal all or part of it. So huge cleavage, more than any other time in my lifetime. The legal challenge of the ACA, is the individual mandate legal? Can the government force you to eat broccoli, or as the way Justice Scalia phrased it? And the answer, and Judge Roberts, people were kind of surprised, he was the swing vote, and he said, yes, it is legal because it's a tax, even though the president didn't call it a tax, but it is a tax. But to everybody's surprise, every lawyer I knew didn't think this was going to happen. The Medicaid expansion is coercive. They've been expanding Medicaid bit by bit over the years, but this is such a big jump that they gave states the opportunity to not take the expansion of the Medicaid. So where is Oklahoma with the ACA? As a state, you've come out that you hate it. You're not going to accept the expansion of the Medicaid. You refuse the state exchange, so you're limping along with the federal one, which is some of your problems. And you're suing over the legality of exchange subsidies. Of the 632,000 uninsured people in the state, 1/3 are eligible for premium tax credits through the exchange, which is run by the federal government. And that's going to play out. I'm not sure how quickly, but it's going to. Only 11% are currently eligible. Only 23% would have been eligible had Oklahoma accepted the state option, which they didn't. There are 11% who currently could be enrolled under state Medicaid rules, and they just need better access. And you're tied with North Carolina and Wyoming for 39th in the uninsured at 17%. Your percentage of uninsured. Texas, you'll be glad to know, is 50th. Generally, it's good old Mississippi that's 50th in almost all of these, but it's Texas here. So I've been asked to leave time for questions and comments. I think we can do that. I'm going to conclude here saying that, just sort of summarizing up, the United States, as you heard, has poor health status. We can't correct it by better health care by itself, because there's so many uninsured in Oklahoma, you're not going to correct it by better health care. Improving health in Oklahoma as a state and the United States as a country means you got to focus on the poor. The ACA could greatly expand coverage to the uninsured, but politics, revenue, and how to implement it are all really in a state of flux at this point. Most people, let me ask for a show of hands. For the students, how many of you have parents who are pretty happy with their own health care now? Yeah. And that's a general issue, and that's why it's so hard to get things changed, because most people are pretty happy, and I'm happy. Support for covering the poor is pretty weak. So I mentioned we have a fiercely partisan Congress and a divided country that's opposed to expand a role for government. But there's a great opportunity for statewide efforts, both public and private, to improve Oklahoma health. So this is my last slide. What could you do next? You do a full court press on smoking and overweight. And you don't necessarily have to spend a lot of money to do that. I'm thinking of the leadership here in this room and elsewhere to really accelerate that. And you've seen with your decline in smoking that you could do that elsewhere. It requires effort, it requires funds, but it doesn't necessarily have to be a huge amount of money. You can do harm reduction strategies for the ravages of alcohol and drug abuse. You can have public and private support for a social safety net, especially as you've done with pre-K. And finally, you could explore, I'm not smart enough to know how you do that here, but viable ways to improve access to care for the uninsured, because it is a moral issue, and there's a strong moral fiber in this state. And you need to figure out a clever way to try to do that. So thank you for having me here. Thank you for the efforts that you've shown to improve health and healthcare. And let's open it up for questions and comments.
was curious what your thoughts are on nicotine vaporizer products. I know nearly every single one of the people that I know socially who smoke have switched in the last 12 months and no longer smoke cigarettes. It seems like it's an explosive thing, and we don't know. I mean, it seems like surely it's healthier than cigarettes, but we don't know.
So I predicted last night to students the first question would be on the e-cigarette, which is good. I mean, it is. So the e-cigarette is fiercely divided the tobacco control people. So those who are optimistic or bullish say just what you said. Wow, if we could move all the people smoking combustible tobacco into the e-cigarette. We don't know how harmful the e-cigarette is, but it's a hell of a lot less harmful than the regular cigarette. So wouldn't that be wonderful? And our illnesses would go down. And I have some smart friends who think actually that it's a nicotine that causes you cancer. It doesn't. It's really a pretty harmless drug, and people can chew gum or wear a patch for a long, long time. So that's the good news. The antagonists are saying, wait a minute, we don't know how safe it is. They're looking at sort of inference data to show that people, in fact, aren't stopping cigarette smoking. They're just using the e-cigarette as a bridge for when they can't smoke socially. They're bringing it into meetings like this, where it's unclear whether it's legal or not to use the vapor. It's glamorizing it. So, and there's a tremendous amount of advertising now. They're selling it in different flavors, cherry, vanilla, etc. They're appealing to youth. And the final worry is it'll be a gateway, so kids will start with vaping and move on to the real thing. And I'm in the middle. So when the journalists call me up on this, they get a flamboyant quote on one side, a flamboyant, I'm sort of on one hand, on the other hand, so I don't make very good press on it. I think we need to wait and see. If what you said happened, I'd say hallelujah, but there are people who think that's not all that's happening. I would say they shouldn't be able to be purchased by youth. They shouldn't be advertised to youth. Philip Morris's of the world are taking over the e-cigarettes, and that makes me really nervous because these are not the bastions of varying public health. And we shouldn't be allowed to use them in a public space. You just say now, because it's hard for me to see who wants to say something.
Okay. That was actually part of my question. The other part of my question was if the movement toward legalized pot, do you think that's going to start us back down the other direction?
Okay, so the issue is, what about pot and its legality and its health? How healthy is it to smoke joints? I've got to think it's probably equally unhealthy to smoke a marijuana leaf as a tobacco leaf. There's a big difference. Marijuana smokers usually aren't smoking 13 of them per day. So there's a dose difference. But the dose response curve for heart disease in smoking is very steep. So someone who smokes 1 or 2 cigarettes a day is still at risk for platelets getting stickier, the arteries being more sticky, and so at risk for clots. So my guess is that low dose pot use doesn't put you at risk, low dose compared to cigarettes, doesn't put you at risk for lung cancer, but probably does for some of the health effects of heart disease and stroke. What does legalization mean? It means there are going to be more people out there using it. I actually not a big, all my liberal friends were shocked when I voted no on legalizing it in California. I think the dynamic, this is very personal, this isn't in science. The big advocates for let's legalize it use medical reasons as the reason, but I think they just want to use it legally. That's the sense I have. And others want to get the revenue from what now is a black market product and a tremendous amount of taxes, and it means you have to raise taxes. I worry about kids driving stoned. I worry about the public safety. I worry about the methods. I also don't like lotteries. I don't like the state sanctioning gambling as a way to raise money, but in that way it's sort of the period. So nobody's really studied the health impact of this. I suspect they're going to be looking at Colorado and Washington very carefully. Those are the 2 good questions I thought were going to come. So I wish I'd bet on some horse races today, too. Yes. I think they're going to bring a microphone to you.
I can shout.
Okay.
What do you think is the best way that people in Oklahoma can put an emphasis on increased access to health care for the poor? Because I think that the idea of personal responsibility holds a lot of people in Oklahoma back from being sympathetic to people who have difficulty accessing health care because they are poor.
Okay. So I'm going to give a political answer, and it's going to be a little bit ugly. And that's to find a good-looking white mother who's suffered in a way maybe from breast cancer for not having access, and then media blast that everywhere. I'm sorry to say it that bluntly, but that's the way it works. That's how the folks, that's why breast cancer gets something like 20 times as much money from the NIH research as lung cancer does, because there was advocacy. And you need advocacy, and you need to shame people. As long as the problem is invisible, and as long as the poor are felt to be seen as unworthy, that's what happens. That's my own answer. What do you think?
Well, I guess I asked because I don't really know, but I think it's a very complicated problem, particularly in Oklahoma. And again, I think it's because, as you said, many people view the poor as being unworthy and have the sentiment around here that, if they were worthy of equal access to health care, then they would work harder and not be poor. And that's very frustrating for me.
Yeah, that was sort of the gist of my answer. I think there's an opportunity now, because the unemployment rate is so high, to find some pretty, and our president does this too, he sort of cherry picks people like this to showcase, but to find people who used to work and got laid off and it wasn't their fault, and they're 55 and they can't get back in the job market, and their parents are grandparents, that kind of stuff. Yeah. I mean, it does, one of the things that's always concerned me is that many of the states that are the most conservative also have the fundamentalist Christian movement. And I would have thought the churches would be speaking out on this, because as I understand the tenets of Christianity, it aligns perfectly with caring for the less fortunate. And yet that linkage hasn't been made, and I don't know why. And it may be that outreach to the churches might be helpful.
Okay, my question is, for the states that opted out of Medicare expansion, or
Medicaid expansion.
do you think that they're just keeping the stone down the road, and once it'll eventually become a burden, like a bigger burden to their states, they're eventually gonna, but they've been slowly increasing the number of Medicaid patients. Is it kind of like how Medicare came into effect when eventually all the states did it? Do you think that's gonna happen?
So the question is, what about those states that opted politically not to expect, because the Supreme Court let them, not to accept the expansion of Medicare? When Medicare went through, nobody had a choice. It was, every old person could sign up for it, and they all did, essentially, unless they had Alzheimer's or something, and then someone signed up for it. Why did the states not do it? The states like Texas, and I suspect like here, were lobbied very hard by the hospitals and the doctors, right, Dean? They said, this is crazy. You're foregoing money. We're caring now for uninsured people, and we could get paid for that. And usually the hospital lobbies and the medical lobbies win. But in these states that hated the president and hated the Obamacare so much, they were willing to make a stand and to give away billions of dollars because of a political principle. And unfortunately, there's not a good lobby for the poor and the uninsured. And for many of these states, now some of the states that originally, the southern states that originally said we're not going to do it, tried to craft compromises. I think Arkansas did, tried, I think in Indiana, which isn't a southern state, but it's a very red state. So some of them crafted some compromises. But for many of them, I think it's 25 or 26, they said, no, we're just not going to do it. Tough. And it's kind of amazing. I also think that the pressure didn't stay on. A lot of this is just political pressure. Picketing, nasty letters, being willing to be uncivil if you believe in something. And some states do that better than other states. Tea Party shows how to do that, but not in the service of this issue. Yes?
Hey, thanks very much for your presentation. I just wanted to comment a little bit on your last little point and the question that was asked about the uninsured. I think that many of the students know this, but for those who don't, I'll just mention this. There is a network here in Oklahoma City called the Healthcare Alliance for the Uninsured, which is a network of the free clinics. They're mostly religious-based, not entirely, and the federally qualified health clinics to provide better organization for the care for the uninsured and even to expand that care. In fact, the Butterworth Foundation, which is a religiously affiliated foundation, has put some $15 million into trying to expand some of these things to become true medical homes for the uninsured, and some of the leaders in this are here, the students that work with some. So I think that the students need to know about.
So you're pointing out that private sector efforts can work. And I have to ask you, or Rhonda, what proportion of the uninsured do you think is currently covered by this private sector? And do you think it's possible to do this end run and cover them all, or cover more of them?
No, we can't cover all of them. It's about 30% now by our best estimates. And I haven't seen, I don't know if Rhonda or Dan have newer figures on that. That was about 2 years ago. We had a commission, a kind of a blue ribbon commission that Kerry Klein and others served on to look at this. The best that we can estimate would be maybe 30%, and that might be the capacity at the present time as well.
Well, 30% is a lot better than many states have done. Rhonda, do you want to comment any further on that? No. Okay. Thanks for that comment, and it shows that the private effort can do. Be interested to know, maybe you can do this offline, why you can't go more than 30%, and whether there be strategies to try to do that. But really, hats off to those in the room who actually made that happen. That's great.
We can take 2 more questions.
Yes.
How effective do you think implementing a single payer system for everyone would be in controlling healthcare costs?
Yeah, the question is, how effective would single payer be in controlling healthcare costs? Well, it's probably the way they do it overseas. And as if you have a single budget, then you can do budgetary control. And one of the reasons that doctors and hospitals don't particularly want single budgets is they know that. And if it's a trade-off in government between raising taxes or crunching down on benefits, there are more voters who are going to be hit by the taxes than are worried about benefits. But there are also opportunities for an economy of scale. I mean, about 20% of a hospital budget is now consumed by trying to process bills. If you go to the basement of the Toronto General Hospital, you'll see a guy in a lumberjack shirt and boots sending bills to the province government, and they'll pay it. You go to the same size hospital in Boston, let's say the Mass General, you'll see 150 guys in striped suits and vests with calculators going through the 500 different health insurance companies that they got a bill for, each which has a different way to game it, each of which the health insurance company wants to take as long as possible to pay. And so the hospital's trying to upcode, figuring it all out. So a lot of money goes into that, a lot of money in doctors' offices. So that's a way that you could save money. Last question? There's one in the back there.
Okay, in southeastern Oklahoma, we're the lowest socially and economically disadvantaged counties in the state. Okay, you said one of the problems here we have is obesity and inactivity. The majority, well, I shouldn't say the majority, a lot of the people in that area receive food stamps, the SNAP program. A woman with 3 children can get almost $800 a month. By them getting that, they get free food. They can buy food from convenience stores with it, which is unhealthy. So they have no motivation to be active or to get a job or do anything. Don't we handicap those people from doing that?
So the question is, you've got poor people getting a lot of money on food stamps. And I'm hearing 2 parts. Somebody forgot it right. One is they're picking the wrong food. Is that it? So they're buying chips and soda instead of healthy foods. That's one question. And second is maybe it's a disincentive for them getting back in the workforce because they've got this handout. Are those the 2 aspects of your question?
Right. You can buy food out of convenience stores almost. It's not heated with your SNAP card. I mean, those deli sandwiches aren't healthy.
So the answer, this is not something that an area I work in near as much as smoking, but the answer is if you go to those communities, you find mainly convenience stores and liquor stores and billboards for cigarettes, alcohol, and Pepsi and Coke. And you don't find the Whole Foods, and you don't find the grocery stores that many of you grew up near. And so it's hard to get salad mixings and all that. Our agricultural policy subsidizes chips and Coke and doesn't subsidize carrots and lettuce and kale. So we have a federal policy that actually makes it cheaper to buy high-dense calorie foods. Whether or not we are creating disincentives to work with those subsidies is a very long conversation. Other countries don't worry about that. We do. And it may be that, you know, on the scale between entrepreneurialism and solidarity, one of the reasons we have the Silicon Valleys of the world is that we're a society that creates incentive for entrepreneurialism. Maybe one of the reasons we're so bad in health is that we don't do much on the solidarity front. But those are huge, big issues that probably you need a separate symposium on. And I think my time is up.
Yes, please